Well, good afternoon, everyone. I was just saying to Merjan, it was nice to wake up to the sunshine today after the last couple of days of rain. I'd like to welcome you all here. My name is Stacey Dawes, and I'm the Health and Community Engagement Lead at Family Caregivers of BC. Thank you so much for taking the time to join us today for our webinar, Family Partnership Across the Critical Care Journey. Very glad to have you here and look forward to spending the next 30 minutes together exploring this important topic. Before we begin, I'd like to acknowledge the land where I'm joining from today. I'm speaking to you from the colonially known as Port Moody on the traditional, ancestral, and unceded territories of the Coquitlam First Nation, as well as the shared territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I'm grateful to live and work on these lands and acknowledge the ongoing relationships that Indigenous peoples have with this territory. Just a couple quick housekeeping notes before we begin. Today's session will be recorded, and we will share the recording with everyone who registered after the webinar. We're also going to be posting it on our Caregiver RX resources page, so it can be accessed more broadly, and you can share this webinar with those that you feel might be interested. We'd also like to encourage you to participate throughout the session. If you have any questions or reflections, please feel free to add them in the chat or the Q&A box, and we'll do our best to address them during the discussion portion at the end of the webinar. And with that, I'm very pleased to introduce our presenter for today's session, Sybil Hoyce. Sybil is a clinical initiatives and innovation lead with Critical Care BC at PHSA, bringing over 17 years of critical care experience across urban and regional settings. Recent work includes leading the provincial quality standards development with Health Quality BC and co-leading the BC Septis Network, advancing data-driven quality improvement and patient and family-centered resources. She holds a Master's of Nursing from Athabasca University and has a strong interest in sepsis, interdisciplinary partnership, and ICU liberation. So Sybil, thank you so much for being here today, and I'll now turn it on over to you.
Excellent. Thanks very much, Stacey. It's a pleasure to be here and talk with you all today about this really important topic. I'm just going to share my slides here. There we go. Okay, excellent. As Stacey said, my name is Sybil Hoyce, and I lead clinical initiatives and innovation with Critical Care BC. I'm grateful to be joining from the traditional lands of the Secwépemc people here just outside of Kamloops, and grateful to be joining today. For those of you who aren't familiar with Critical Care BC, we're a provincial health improvement network, and we partner with critical care leads from each health authority on data-driven service and quality improvement initiatives, and we aim to improve the system and patient outcomes. We're engaging all of the methods you see here listed to reinvigorate something called the ICU Liberation Bundle, which provides a roadmap of care planning considerations forming the foundation of critical care practice. It also has the added benefit of reducing the short and long-term complications of critical illness, which obviously supports recovery. Last year, we heard from our health authority partners that there was a pressing need to collectively refocus on the basics of critical care following the unprecedented disruption of clinical practice through the pandemic. The foundational ICU Liberation Bundle was being implemented before the pandemic across the province, but high staff turnover left us in a position where half our staff were not familiar with this foundational framework. And so for the remainder of the presentation, I'll highlight how families are an integral part of this work. And so today we'll learn how to engage families as partners through critical care and recovery. We'll learn how to apply some practical communication strategies that empower caregivers, and we'll learn how to support patients and families during post-critical care transitions. So I thought it would be helpful to first set the context of patient and family journey through emergency department triage to critical care. So first, there's the recognition to go to hospital, either by ambulance or by car. And then there's the parking issue if you go by car, which is interesting across the province. And then there's the ED registration and triage assessment process to see how quickly you or your loved one needs to be seen by a physician. And that's in relation to the rest of the patients in the emergency department at the time. Then there's the wait for lab work and review of the lab work. And if needed, the wait for a critical care physician to come to the emergency department to see you or your loved one to determine if a critical care admission is needed. Then there's the wait for a critical care bed. And this time can seem like an eternity, especially in the environment of a busy emergency department, which is commonplace these days. Most of our emergency departments are very busy. There's also the humbling realization that you or your loved one is sick enough to require critical care treatment, which can be shocking and scary all at the same time. And I wanted to share this drawing. A colleague and friend drew this image many years ago, and I've kept it handy. It reminds me that the admission process to critical care is organized chaos most of the time, with many things happening at once. And while each person has their role, those roles and the reasons for some activities are not known to families. And this is not always communicated well, which can leave families feeling frightened. This is a key point in time where trust can be established or lost, depending on the approach of the staff. And that trust being lost or gained can influence the entire trajectory of care, and it's critical to both patient outcomes and the clinician experience. And so while the immediate admission process is happening, we do recommend that someone from the care team update the family, even briefly, and give an approximate time when they'll be taken to see the patient. Culture around this process is shifting to make it the aim to have family in the room to see the patient as soon as safely possible. As soon as the patient is settled and stable, there are key elements of care that are shown to make the biggest difference in critical care survival and long-term outcomes. And I'll talk about what those are now. So from the moment the patient is stabilized in critical care, the minds of staff and providers should be focused on these 6 strategies to limit secondary injury. And we can't do anything about the initial injury or illness, but we can prevent the situation from getting worse by focusing on these 6 elements. And that's regardless of the injury or illness the patient is experiencing. So that's why it's the foundation of critical care practice. So the ICU Liberation Bundle is the staff roadmap for how to implement the 2018 PADIS guidelines. And PADIS stands for pain, agitation, delirium, immobility, and sleep. And these were published by the Society of Critical Care Medicine, which are internationally recognized guidelines. The initiative highlights key elements of critical care that are modifiable within the walls of critical care units, the items that we can control to reduce the impact of critical illness. The A to F list of elements is what makes up the bundle. And so while the family engagement and empowerment piece is the last one listed, it's meant to be weaved through the patient care journey every day. And so across critical care units, patients experience predictable and preventable harms, including uncontrolled pain, oversedation, delirium, immobility, sleep disruption, and varying degrees of isolation from the family. Combined, these drive longer ventilation dependence or breathing tube dependence, longer stays, poor recovery outcomes, and decreased trust from families as they are left in the dark to varying degrees with either low communication or communication that is riddled with jargon. The power dynamic between clinicians and families is also a concern that needs to be addressed. And we do recognize that up to 80% of critical care survivors will develop post-intensive care syndrome, or PICS as we call it. And this means they experience symptoms of cognitive, emotional, and physical symptoms that can last for years, affecting quality of life, post-discharge resource use, and readmission to hospital and critical care. And while 80% of survivors do develop this, we do want to highlight that 20% don't. So we do have some hope. And 80% is a considerable human and system burden that we can modify. And this is what we're trying to do now. And so this is about consistently doing the basics of critical care really well every day for every patient and family. And so what is post-intensive care syndrome? So this is deeply interconnected systems, including social and economic deficits. Impairments in one area usually trigger or can sometimes worsen challenges in the others. And it's important to note that this varies, the severity varies for across patients in that sometimes it can last weeks, but we have come across situations where patients experience PICS for years upon discharge. This can impair quality of life, their ability to return to work and previous life activities. It can lead to depression, anxiety, and symptoms of PTSD. And this bullet here, the 1 in 5 survivors can experience all three. That's a higher percentage than combat veterans returning from Afghanistan. So this is really, really impactful for patients and families. And as you can imagine, it also impairs family and caregiver health. And in the last probably 10 years, it's become more aware within studies that patients and families also experience their version of PICS, and that's been coined PICS family. And for both patients and family, this results in overwhelming deficits in well-being. And so you'll see on the left side some non-modifiable risk factors for PICS. So remember I said that we can't do anything about the initial insult or the concurrent conditions the patient came in with, such as their severity of illness or how frail they are, or if they had sepsis as a primary or concurrent critical illness. Whether they had any pre-existing impairments. Also, education and their literacy level can impact their experience of PICS and also the severity of it. And so can demographic factors like their age or their baseline function. But we can do something about the modifiable. So this is the ICU Liberation Bundle on the right. And those are all things that we can modify within the critical care walls. And so F was the last piece in that A to F bundle, so family engagement and empowerment. And family is so valuable in helping us understand how their loved one has previously experienced pain. If there are chronic pain issues or how they historically managed pain, and also how they communicate they're having pain. Are they silent about it or do they speak up about it historically? And that will help us understand how we can learn more accurately if they're experiencing pain and how much of it, and if the medications we provide are working. As clinicians, we need to assume that critical care treatment or injury is painful. Remember, often patients have tubes in every orifice, and sometimes we make holes to put IVs and tubes or drains. And so your partnership and understanding how they communicate pain is essential to assessing and treating it. And any family history you can provide about substance use is valuable, so we can ensure we provide enough medication to counteract the tolerance level that they've likely built up. It's not about judging substance use, but ensuring we have the information to alter our approach and provide enough sedation so that they're comfortable. We also need family to help reorient the person to the patient, to the current date and time, reminding them what day it is, asking them to squeeze your hand, and then reassuring them that you're there by their side. It also helps to read to the patient so that they hear your voice. And we also need to know about any issues they've had previously with breathing, as this can affect how they breathe on a ventilator. Delirium is often really distressing for a family to see because their loved one may say or do things that are totally out of character. And this is due to the illness process or the environment or the medication that we've given. And so family can let staff know if their loved one seems off. There are no drugs to treat a delirium, but we can reduce drugs that cause it. We can alter the environment to prevent or manage it. And that includes having family present and most importantly, to treat pain to prevent it, as pain is the leading cause of delirium. Translation services can also help too by explaining things and providing tools that use the patient's language. Family can help with mobilization too. Even getting the patient to squeeze their hand or give high fives or move their feet and legs up and down can help. Being in critical care can lead to profound muscle loss as patients are immobile for days or weeks. Once patients are improving and able to move from bed to chair, family can also encourage the patient to stay up in the chair longer, to stay awake during the day, and do as much of their own care as they can in order to prevent some muscle loss. But also this helps them stay engaged in their own recovery, building their confidence in the slow journey through that recovery. We also have tools in the critical care units that can help with communication that are being implemented in critical care units around the province, and I'll review those now. So many of the critical care units around the province have whiteboards in each room that highlight key information about the patient and the plan for the day. For example, they can highlight what name the patient prefers to be called, the name of the staff, the mobilization plan and goal for the day, or if their patient can stand or walk or on their own, or if they need help. The whiteboard's used as a communication tool with the team and family and can hold information like when the next family meeting is with a doctor or if the patient wears a hearing aid. Because many of our patients have a breathing tube and can't talk, we also have letter boards or picture boards that we can use so they can point to faces on a pain scale that represent how much pain they feel or how tired they are. Families can use these tools too, and if they don't see them, you can ask for them. During COVID, many units had iPads donated from hospital foundations to help patients FaceTime with loved ones or watch videos to help them stay awake during the day. One health authority is also creating a healthcare provider learning module related to augmentative communication, and the intent is to make that available to all health authorities. So there's certainly some attention provincially around this. Family and patients might find translation services helpful to explain their illness and treatment or next steps in a language they're more comfortable with. And many hospitals now have Indigenous patient navigators that can draw on resources available specifically for that population. Some units have started critical care diaries for patients or family to write down the events of the day and progress. We've learned from patients and families that these can help them make sense of their care while recovering, as sometimes the days or events can blend together or are remembered incorrectly, which can lead to distress as their memory is slow to return. And we also have get to know me sheets that are developed by the University of Washington. And these are designed to share patient likes and dislikes to help staff see pictures of the patient in healthier days and get to know them as people and not just as the gallbladder in bed 9. In some units, families are invited to be part of interdisciplinary rounds so they can hear status updates directly from the care team and they have an opportunity to ask questions or provide more information that can help us individualize the care the patients receive. It also helps build trust between the care team and the family. And if the patient is awake, sometimes these interdisciplinary rounds happen at the bedside, so the patient can be part of them. And there are so these are some of the ways that family can help with communication and be involved in critical care treatment. But how can family help with recovery after the critical care experience? So now that we've reviewed what can be done to support patients within the walls of critical care units, let's focus on how we can support them in their recovery beyond the walls of the critical care units. So these are some of the statements that we've heard through patient and partner engagement and critical illness recovery research that I've been involved with over the last decade. This last statement here, the one that's highlighted on the right, this is key. we thought it was just us. This statement represents the profound isolation that critical care survivors and their families can experience, and this is at the forefront of my mind as I lead this work. I have a link here to a recent 10-minute film about from the American Medical Association, and it documents the story of an ICU survivor who developed PICS. It features interviews with clinicians and researchers to explore what PICS is, what causes it, and ways to support patients and families. Through research with patient and family partners, we've learned that written discharge information can really help them prepare for their journey and feel supported throughout it. So we now have a recovery after critical illness guide that can be used across the province. Only Fraser Health had a recovery guide, and it needed to be updated anyways. So we did that work together with leaders from across the province so we could all use the same resource. And so this guide is now available in 4 languages. So English, Punjabi, French, and Chinese and French. Now that the French version is done, we'll update the English poster that you see here with links to all of the translations so it can be posted in waiting areas. At the end of the recovery guide, we've also highlighted some community agencies that are available to help support folks in their recovery, including some culturally specific organizations. So like I mentioned, we have this poster for waiting room areas. We also have the recovery guide posted on our Critical Care BC webpage. We've communicated it through our critical care nurse and allied health community of practice, which has over 200 members from across the province. We host a Critical Care Connect webinar 2 or 3 times a year. And so we do share it there as well. And we have a monthly newsletter that we send out. The recovery guide has also been shared with Pathways BC, and this is used by GPs and NPs across the province that support patients in the community. So this allows them to see the guide, learn it, and review it with their patients. And we also work with them to create a recovery essential care pathway or like a quick sheet that has emailable resources. So GPs and NPs can email these to their patients. And Family Caregivers of BC is also helping us share the resources with caregivers who reach out to them for support. And so we are seeing some recovery clinics being developed across BC now, which is fantastic. The beginning of COVID saw the development of post-COVID-19 interdisciplinary clinical care network, and they developed self-management clinics, including peer support for COVID survivors. And this was done with COVID funding. The vision was to extend to COVID plus clinics, but funding and governance are being sorted out now, and the added layer of critical care also adds more complexity than just general COVID and general recovery from hospital. And also the presence of sepsis increases the complexity of recovery even further, and it's estimated that half of critical care patients experience sepsis or septic shock. So with continued funding and governance challenges, some of the intensivists across BC, the ICU doctors, are taking it upon themselves to start their own clinics, and Critical Care BC is working to support them by bringing together like minds for some standard processes and evaluation criteria. Well, not an official working group with us, we are working on this in alignment. They are all reviewing the recovery guide with their patients. And Northern Health has worked with their Indigenous patient partners and staff to create a 7-minute video that provides an overview of the recovery process. And this was in response to hearing that Indigenous people prefer a video to written communication. And so that video link has been added to the recovery guide, and a few other health authorities have now added it to their ICU or critical care websites as a resource. The goal of bringing these like-minded clinical leads together is standardized data, practice, and shared resources to create some quality and efficiency practices. And so thank you kindly for sharing your time with me, and I hope that you've learned more about how we're trying to engage families as partners and apply some communication strategies to support patients and families during their critical care transitions. And just wanted to finish, remember that every drop in the water creates a ripple. And in the case of the ICU Liberation Bundle, the population and system level improvements and efficiencies can really add up in terms of provincial and regional critical care access. So thank you for your time, and I'm happy to answer any questions or hear any comments or suggestions.
Thank you so much, Sybil. That was a lot of information packed into a short amount of
Yeah.
time with some really great resources and practical information. I just want to put it out to the group here because we just have a few more minutes. So if you have any questions, just kind of pop it into our chat box here. But in the meantime, Sybil, I'm just wondering if you have like one takeaway for like a practical tool or tip for those busy healthcare teams to integrate some of this communication with families. What would that be?
I would say review the guide.
Review the guide. Yeah,
Review the
we
guide, or
definitely.
at least let them know that it's available. And,
Mhm.
you can provide a digital or written copy in some areas. Like I mentioned, all of the clinics that are running already are already reviewing it. But if as soon as you know that the patient and is going to survive their critical care experience, you can bring out that recovery guide, the early intervention and early knowledge about what their recovery might look like for them and some of the challenges, it can help them prepare ahead of time. So, reach out to friends and family. And if those friends and family are offering support, take it. You might not feel
Mhm.
like you want it or you need it right at the time, but honestly, take it. Any support that friends or family can offer, and it'll be helpful during the journey for recovery.
Mhm. And this guide is it's geared towards family and friend caregivers as well as healthcare providers, correct? Yeah.
The guide is totally geared towards patients and families.
Yeah.
It was created for them. What we recognize we need to do in critical care is help staff and providers know that it exists, and
Hmm.
also help teach them about post-intensive care syndrome. This is something
Hmm.
that's come up in the last, 15, 10 mostly years. And so it's definitely something that not every critical care nurse or allied health or even medical staff know about. And so
Hmm.
we've got a bit of an uphill kind of way for that. And I do see Amanda's question there about how to help healthcare providers know about this. And we have created educator slides. And I have the community practice meeting actually right after this. And so that's where I'll be introducing those slides to them. And also, we're developing a pamphlet or a poster to help them so that they can look at that guide before they go in to review the guide with patients and families. So it'll highlight some key points to make sure that they cover with the patients and families as they're going through that guide.
Excellent. Thank you.
Yeah, thank
And
you.
just a reminder to those, because I've seen the question a couple of times. Yes, we will be sharing the slides. We will be sharing the presentation as well. We will be providing a follow-up email to everybody that is registered. And this will also be posted on our Caregiver RX resources page on our Family Caregivers of BC website. Everything that Sybil has referenced today, we're going to include as well in the follow-up email. So links to all of these incredible resources. Um, and so, with that being said, Sybil, thank you so much for being here today. Sybil and I have kind of been working together for, I'd say it's going on almost a year now
Almost.
on some
Yeah,
of these
yeah,
things. So,
yeah,
so grateful that that you were free to come and share this knowledge. Just the ICU Liberation Bundle is just such an incredible resource and initiative.
yeah,
And I'm just really thankful that you've invested your time and your expertise into getting this up and rolling again post-COVID. Um, so I'd like to thank you all for being here as well with us today and sharing your time and investment in supporting caregivers. And Marjan has put the survey link in our webinar chat here. I encourage you to fill this out. It really does guide us in what type of webinars that we do provide for healthcare providers and our social sector staff. Um, so I just want to thank you, Sybil. I want to thank you all that attended today.
pleasure.
And yeah, look forward to what's going to become of this. Hopefully, that small drop turns into a tsunami of change.
Totally. Yeah. Every little bit helps.
Yeah.
Okay, excellent. Thanks,
Thank
everyone.
you.
Have a great
Thank you
day.
all.
Bye.
Thank you so much, Sybil. Thanks, everyone. Have a good day.